Airway management can be defined as the provision of a free and clear passageway for airflow. Obstruction can be partial or complete, and it can occur at any level from the nose to the trachea. As seen here in the anatomical position, the axis of the oral cavity sits at near right angle to the pharyngeal and laryngeal axes. The sniffing position has been widely accepted as the best position for alignment of the airway and involves the ear, or external auditory meatus, being parallel with the sternal margin. This position is quite often naturally adopted by patients in severe respiratory distress. The placement of the patient into the sniffing position is as follows. First, the movement of the head anteriorly and addition of padding under the occiput aligns the pharyngeal and laryngeal axes. Head tilt then aligns the oral axis with these other axes. Managing an airway in patients who are morbidly obese can be challenging. These patients are often ramped by placing pillows and sheets under their upper shoulders and head. These images show a patient in the sniffing position, as would be sufficient for the general person, and the same patient ramped to align the ear with the sternal margin. In addition to a head tilt, other fundamental airway manoeuvres are a jaw thrust and opening of the mouth. To perform a jaw thrust, you place your index and other fingers behind the angle of the mandible and the thumbs on the mandible itself. The thumbs open the mouth while the fingers are used to apply pressure upwards and forwards. This movement causes the condyles of the mandible to sublux anteriorly in the temporomandibular joints and displaces the mandible and tongue anteriorly. An isolated jaw thrust is recommended in patients where there is a risk of cervical spine injury. Otherwise, it can be used in conjunction with a head tilt in what is known as a triple airway manoeuvre. A nasopharyngeal airway is a soft airway adjunct which is inserted into the nasal passageway that provides airway patency by separating the soft palate from the posterior wall of the pharynx. It has several advantages in that it can be used in the presence of trismus, an intact gag reflex, and with patients with oral trauma. Insertion is also a quick procedure. While there are no contraindications to the NPA, its use is cautioned in a few types of patients. These include patients with potential or known basal skull fractures due to the potential for insertion through a fractured cribriform plate into the cranial vault, and also patients with known bleeding diatheses, for example, heparinized or warfarinized patients. This is due to the increased risk of bleeding. In preparation, you need a water-based lubricant and an appropriately sized NPA. It is sized from the tip of the nose to the tragus of the ear. Then lubricate the exterior of the tube. This minimises the trauma during insertion. In preparing the patient for the procedure, where there is no risk of cervical spine injury, hyperextend the head and neck to align the axes. Otherwise, keep the head in a neutral alignment. If there is no evidence of nasal deformity, it is recommended that the right nostril be used because it is typically larger and straighter. If a nasal deformity exists, the most patent nostril should be selected. Facing the bevel towards the septum, insert the tube into the nostril and follow the natural curvature of the nasopharynx until the flange sits against the nostril. This means inserting it parallel to the mouth, not upwards and towards the bridge of the nose. Avoid pushing against any resistance. If resistance is felt, remove the airway, review the technique and reinsert using the other nostril. If inserting into the left nostril, the bevel is again placed facing the septum and the airway rotated 180 degrees after it enters the nasopharynx. You should assess for complications, with the most common one being airway trauma and bleeding. Incorrect size of placement will compromise the effectiveness of the NPA. While it is uncommon, necrosis of the anterior aspect of the nose may also occur if the diameter of the NPA is too large. If there is evidence of blanching around the external nares, the NPA should be removed and a smaller one inserted. Other complications include stimulation of gag reflex in sensitive patients and small diameter airways becoming obstructed by secretions or the soft tissues of the pharynx. The oropharyngeal airway is a curved plastic device that is designed to follow the curvature of the palate. It's designed to be used in unconscious patients requiring airway support and should only be inserted in those patients who have absent laryngeal and pharyngeal reflexes. Insertion in patients with intact reflexes may stimulate gagging, vomiting, aspiration, or laryngospasm. It will also be unable to be used in patients with trismus or significant oral trauma. It works to separate the tongue and soft palate from the posterior pharynx. Prepare the equipment by selecting an appropriately sized OPA and having suction equipment handy. To size, place the flange of the OPA against the patient's cheek, parallel to the front of the incisors and going to the angle of the jaw. Where possible and no risk of cervical spine injury exists, prepare the patient by placing them into the sniffing position and with one hand provide a jaw thrust. Ensure the mouth is clear of all secretions and suction if required. Using the other hand, hold the OPA by the flange and insert it into the patient's mouth, with the tip pointing towards the roof of the mouth. This avoids unnecessary trauma to the delicate tissues in the mouth and inadvertently blocking the airway by pushing the tongue backwards. Once the tip reaches the level of the soft palate, gently rotate it 180 degrees until it comes to a rest of the tongue and the flange is resting against the lips. Confirmation of placement of an OPA and NPA are similar, by listening for upper airway sounds indicating a potential obstruction. If a snore is still heard, you might be required to provide further jaw thrust, consider reinsertion of the airway or additional airways, or lateral positioning of the patient. Also observe chest wall expansion and listen for breath sounds. A supraglottic airway can be used when there is actual loss of airway patency and/or airway protection. Ventilation with a supraglottic airway is considered more efficient and easier than with a bag valve mask.
This is the laryngeal mask airway supreme. Special features include an inflatable cuff which is designed to conform to the contours of the hypopharynx. It also contains a built-in bite block and gastric drainage port. This port facilitates drainage by passing an orogastric tube into the patient's stomach.
To note with this model, the contents can be expelled from the gastric drainage port during CPR, which poses a risk to ambulance personnel. To mitigate this risk, protective equipment should be worn and a drainage bag connected to the port. Prepare your equipment. You'll require a range of sizes of LMAs, 50ml syringe, a tie or tape for securing, water-soluble lubricant, bag valve mask with attached filter and end tidal device, suction equipment, oxygen source, and stethoscope. Sizing the LMA is based upon the weight of the patient and can be found on the packaging. Open the packaging and remove the protective case. Remove the red safety lock and attach a 50ml syringe to the pilot balloon. Hold the LMA in the non-dominant hand and withdraw air while simultaneously compressing the LMA cuff, ensuring the distal end of the cuff is curled anteriorly. After achieving the desired cuff shape, disconnect the syringe from the pilot balloon. Lubricate the posterior surface of the mask with lubricant. Prepare the patient by placing the head in the sniffing position if there is no risk of spinal injury. If spinal precautions are being taken, maintain the head in a neutral position. Take note of any predictors of difficult airway insertion. Open the patient's mouth and position the LMA's distal tip against the inner aspect of the upper teeth or gums. Slide inwards and continue to insert the LMA so the device follows the curvature behind the tongue until definitive resistance is felt. Ideally, tape the airway in place prior to inflation of the airway cuff. This will ensure that the airway stays seated and does not back out once it is inflated. Inflate the LMA cuff to the desired volume as stated on the packaging. There is no requirement to insert a bite block. Confirm the correct placement by ensuring a minimum of 1 cm gap between the upper lip and fixation tab. Observe equal rise and fall of the chest and ensure bilateral breath sounds. Analyse the end tidal carbon dioxide output. Complications include failed insertion and ventilation or having an ineffective seal. Removal of the LMA and return to BVM ventilation may be required. The technique should be reviewed and reinsertion attempted. Other complications include traumatic complications relating to local tissue damage, stimulation of the gag reflex with the possibility of precipitating vomiting and aspiration, and precipitation of laryngospasm on insertion and removal. Inadequate ventilation is the overriding indication for assisted ventilation. It should be provided as soon as possible in any patient where spontaneous ventilation is inadequate or absent. The notable components of the bag valve mask are included here. Assess the patient for difficult bag valve mask ventilation and prepare the patient by placing them in the sniffing position if there is no risk of spinal injury. Apply the face mask to the patient. The lower border of the mask's cuff is first applied between the lower lip and the chin, after which the upper aspect of the mask can be placed down across the bridge of the nose. A seal is achieved using the CE grip. The thumb and index finger of the hand apply sufficient pressure on the face mask to achieve a good seal. The ring and middle fingers grasp the bony ridge of the patient's mandible, and the fifth finger hooks under the angle of the mandible. These three fingers apply a jaw thrust. The fingers should not be placed in the submandibular space as it can contribute towards airway obstruction. It should be noted that the patient's jaw is lifted up to meet the mask rather than excessive downward pressure being applied that may worsen the functional obstruction. At the same time, the entire hand also attempts to keep the head extended. The opposite hand is free to gently squeeze the bag. The patient should be ventilated at a rate and tidal volume adequate for the patient presentation and pathological processes. If the patient still has an intrinsic respiratory effort, assisted ventilation should be timed with the patient's inspiratory effort. If the patient is tachypneic, it may be appropriate to deliver an assisted breath with every third or fourth patient inspiration. Continually assess adequacy of ventilation. Look for chest expansion, improving pulse oximetry reading, improvement in the patient's colour, and ensure there is no increasing abdominal distension. Listen for any hiss of escaping air from a poorly sealed face mask or a fluttering sound from the cheeks can indicate obstruction to gas flow. Feel for compliance on squeezing the bag or leakage of air against your hand from a poorly sealed face mask. Compliance can be caused by obstruction or other intrathoracic pathology. Small adjustments to the mask position on the patient's face can be made as needed to correct any leak by tilting to the left or right. With optimal technique, significant difficulty with BVM is rarely encountered. Because difficulty is defined in part by the skill of the clinician, when it is encountered, the most experienced airway clinician should take over BVM ventilation and lead the approach to difficult BVM. As soon as difficulty is noted, head repositioning and an increased jaw lift should occur almost simultaneously. A more pronounced jaw lift is best performed with a second person. Two-person mask ventilation is easy to perform and is often much more effective than one-person BVM. Two different two-handed techniques are shown here. If any predictors of difficult mask ventilation were identified, consider implementation of strategies to mitigate or reduce their impact.